Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 577 of our pharmacotherapy series, which majors in geriatric drug use. The first case reads, JCC, a 67-year-old woman, who is 5 foot 6 inches tall, weighing 145 pounds, presents to the emergency department complaining of shortness of breath for the past 2 days. She was in her usual state of health until 4 days ago, when she exhibited flu-like symptoms consisting of fever, cough, and mild wheezing. JCC has a history of asthma, diabetes mellitus, hypertension, headache, and GERD. Her current medications include G-lipotide 5 mg daily, lisinopril 10 mg daily, metoprolol 50 mg twice daily, lansoprazole 30 mg daily, ibuprofen 200 mg every 6 hours as needed for headache, albuterol metered dose inhaler, abbreviated as MDI, 2 puffs 4 times a day as needed for shortness of breath, and fluticasone HFA, 44 micrograms per puff, metered dose inhaler 2 puffs twice daily. Her drug regimen has been unchanged for the past 2 years, and she reports taking all medications as prescribed. The only recent change has been the need for albuterol every 3 to 4 hours for coughing and wheezing during the past few days. So my first question to you reads, what factors, including medications, may have contributed to her acute asthma exacerbation? Management of acute asthma exacerbations in previously stable elderly asthmatics should begin with a review of the medication history for asthma-inducing agents. Aspirin and other non-steroidal anti-inflammatory drugs are known to induce acute bronchoconstriction in adult asthmatics. JCC should be queried about her previous, especially recent, use of ibuprofen in relation to her asthma symptoms, and these agents should be avoided if associated. An alternative agent for pain control is acetaminophen. Non-selective beta blockers, including topical ophthalmic formulations, can precipitate acute bronchoconstriction and should be avoided in patients with reactive airway disease. Although cardio-selective beta blockers are generally considered safe for use in patients with asthma, it is important to recognize that cardio-selectivity may be lost with higher dosages. Because JCC has been taking low-dose metoprolol, a cardio-selective agent, for years without problem, this medication is unlikely to be contributing to her current asthma exacerbation. One of the most important triggers for asthma exacerbations is respiratory infection, particularly viral. JCC reports the recent onset of symptoms consistent with influenza, and this is likely precipitating her current pulmonary symptoms. As a future prophylactic measure, JCC should be counseled to receive the influenza vaccine annually. JCC does not recall every receiving the pneumococcal vaccine. In adults aged 65 and older who have never received the pneumococcal vaccine or who are unsure like JCC, they should receive a one-time dose of pneumococcal conjugate vaccine, abbreviated as PCV13, and 12 months later, they should receive the pneumococcal polysaccharide vaccine, abbreviated as PPSV23. My next question to you reads: are the medication regimens used to treat asthma in elderly patients different from those used in children and younger adults? Should JCC's maintenance asthma regimen be changed? Medications used in the management of persistent asthma in the elderly are similar to those used in younger patients and consist of bronchodilators in combination with anti-inflammatory agents. Drug selection and monitoring may be more complicated in the elderly because of the greater likelihood of coexisting medical conditions and increased potential for drug disease and drug-drug interactions. Inhaled beta-2 agonists are an important class of drugs used to treat asthma in all age groups. The low incidence of drug interactions and reduced side effect profile make inhaled beta-2 agonists ideal for use in the older asthmatics. However, these agents can cause dose-dependent systemic side effects, such as tremor, tachycardia, hyperkalemia, and arrhythmias, which are of particular concern in patients with cardiac conditions. Inhaled corticosteroids are the preferred treatment for all forms of persistent asthma, yet they may be underused in the elderly. Though generally well tolerated, elderly patients receiving high-dose therapy are at an increased risk for osteoporosis, cataracts, skin thinning, and bruising. In addition to the well-known complications associated with systemic corticosteroid use, these agents can acutely cause confusion, agitation, and hyperglycemia. JCC is currently maintained on low doses of an inhaled corticosteroid, that is fluticasone, in combination with a short-acting beta-2 agonist, that is albuterol, and this is an appropriate regimen for a patient with mild persistent asthma. Following resolution of her viral infection, JCC's asthma control should be re-evaluated within the next 3 months for a step up or down in therapy. Because JCC is postmenopausal, she is at risk for osteoporosis. Calcium and vitamin D supplementation should be initiated. Appropriate use of metered dose inhalers is difficult for most patients, but may be particularly problematic in the elderly population because of decreased hand strength or arthritis, difficulty timing actuation to inhalation, or impaired mental function. The use of spacer or holding chamber devices can minimize the coordination necessary for proper use of a metered dose inhaler and may reduce the incidence of systemic and local, such as cough, hoarseness, and thrush, side effects associated with inhaled corticosteroids. JCC should be discharged with a spacer device to use with her albuterol and fluticasone metered dose inhalers. Even though JCC previously used a metered dose inhaler, she should be asked to demonstrate her metered dose inhaler technique and re-instructed, if necessary, to ensure she is using the inhaler and spacer correctly. If JCC is unable to correctly use her metered dose inhalers with a spacer, use of nebulized solutions, breath-activated inhalers, or dry powdered delivery devices should be considered. JCC was admitted to the hospital and given intravenous methylprednisolone for 4 days. She was then discharged home with a new prescription for prednisone 40 mg daily for 7 days. 3 days after JCC is discharged from the hospital, she presents again to the emergency department. This time, she is accompanied by a neighbor who noted that JCC suddenly became forgetful and confused, and continues to have difficulty breathing. Her neighbor reports that JCC has been staying in bed for the past 2 days and has not eaten much. JCC has a low-grade fever, and chest examination reveals faint breath sounds with light crackling rales over her right lung base. A chest radiograph confirms the diagnosis of pneumonia. My next question to you reads: how is JCC's clinical presentation consistent with community-acquired pneumonia in the elderly? Community-acquired pneumonia is one of the most prevalent causes of hospitalization and death due to infection in adults in the United States. In a large population-based study of community-acquired pneumonia, adults aged 65 to 79 years were found to have an incidence of pneumonia requiring hospitalization that was 9 times as high as those aged 18 to 49. And 25 times as high in those aged 85 and older. Risk factors for community-acquired pneumonia in all adults include age greater than 65, COPD, smoking, alcoholism, aspiration, and chronic medical conditions such as heart, renal, and liver disease. Streptococcus pneumoniae is the most common cause of community-acquired pneumonia in the elderly. Respiratory symptoms and fever are often subtle or absent in older patients with pneumonia. Instead, like JCC, they may present only with altered mental status, delirium, acute confusion, memory problems, or a decline in functional status. Delirium or acute confusion is a common presentation in elderly patients who may have new-onset lower respiratory infection. The next question reads: how should JCC be treated for her respiratory infection? In many cases, management of pneumonia in the elderly requires hospitalization because they are at greater risk for mortality and complications. Early empiric antibacterial therapy is particularly important for older patients with pneumonia. JCC should be hospitalized again and treated aggressively for pneumonia with broad-spectrum IV antibiotics. The Infectious Diseases Society of America, American Thoracic Society Consensus Guidelines on the Management of Community-Acquired Pneumonia in Adults recommends treatment of most hospitalized non-intensive care unit patients with a respiratory fluoroquinolone, such as moxifloxacin, gemifloxacin, or levofloxacin, or beta-lactam plus macrolide, and for ICU patients, the recommendation is for a beta-lactam plus either azithromycin or a respiratory fluoroquinolone. After 7 days of hospitalization, JCC is discharged home with an oral antibiotic to finish the 14-day course of therapy. My next question to you reads: what preventative measures are available to JCC after she is discharged? Once patients are stable and ready to be discharged home, they should be switched to oral antibiotics to complete their therapy at home. Both influenza and pneumococcal vaccinations are beneficial and recommended in the prevention of community-acquired pneumonia. The CDC now recommends pneumococcal conjugate vaccine, that is PCV13, for all adults aged 65 and older who have not previously received it, followed by the pneumococcal polysaccharide vaccine, that is PPSV23, 12 months later. If the PPSV23 has already been received, the dose of PCV13 should be given at least 1 year after. JCC's immunization status should be confirmed, and as a preventative measure, JCC should be offered both influenza and pneumococcal vaccines after she is discharged from the hospital. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 578.